Good evening. Welcome to the first Food for Thought lecture series for the calendar year 2021. This lecture series has been a valued community tradition of Trinity University for more than 30 years. Tonight's discussion is brought to you by Trinity University Alumni Relations and Development Division and the Office of Special Events as part of Trinity's commitment to lifelong learning. The lecture was just approved this afternoon for continuing medical education, CME credit. Trinity University is facilitating this CME credit opportunity that has been generously coordinated and approved by the Texas Orthopedic Association. My name is Marc Strode, Chief Executive Officer of Methodist Hospital Stone Oak here in San Antonio, Texas. We are a 284 licensed bed hospital spanning across two campuses located in the north central part of our community. We are part of Methodist Healthcare, the market leader for acute healthcare services in San Antonio and South and Central Texas. We are a 50-50 joint venture between HCA, Hospital Corporation of America, and Methodist Healthcare Ministries, our local not-for-profit owner. I have had the privilege of leading with Methodist for over 23 years. Prior to Stone Oak, I served as the CEO of Methodist Hospital Texan, and prior to that, CEO of Val Verde Regional Medical Center, a managed hospital by Methodist. My first job after graduating from Trinity University in 1998 with my master's in healthcare administration was with Methodist Hospital as an administrative resident. And prior to my studies at Trinity, I attended Texas A&M University, where I received my bachelor's in industrial engineering. So yes, for better or worse, there's an Aggie running the hospital here. It is now my distinct pleasure to introduce tonight's speaker, Dr. Adam Bregman. Adam has a unique background as the only physician that is Texas board certified in both addiction medicine and orthopedic surgery. After several years as a leading orthopedic surgeon within his own practice, Texas Spine Care Center, Adam founded New Hope in an effort to bring innovation to pain management and opioid treatment. The number one reason people take opioids is orthopedic related, which is why Adam has made it his personal goal to be a leader in this area. Adam is a sought after speaker, published researcher, and a regular opinion contributor to The Hill. His most recent lecture was a presentation to the Texas Medical Association about the new opioid rules and best practices. He is a proud member of the American Society of Addiction Medicine and the most recent past president of the Texas Orthopedic Association. He was named one of the top doctors of San Antonio in 2015 and received Texas Super Doctors Rising Star Award each year beginning in that year through 2019. In addition to his medical expertise, Adam represents New Hope in its lobbying efforts to change outdated policies at the state and federal level. Adam received a master's in hospital administration at Trinity University in 2003 and his medical doctorate at the University of Texas Medical School in San Antonio in 2007. Adam went on to his orthopedic residency at the prestigious University of Florida Shands Hospital System before returning once again to San Antonio to complete his spine fellowship from the South Texas Spinal Clinic. He proudly calls San Antonio home, and he and his wife, Chrissy, have two young children. I've known Adam for 17 years and consider him both a friend and a colleague. And while he is technically expert in the realm of the operating room suite, I will tell you he also excels in the collaboration with other doctors and nurses in leading and organizing the care of sometimes very sick and complex patients. And speaking of his patients, I visit with them regularly and they absolutely love Adam. Thank you, Dr. Bruggeman, and welcome.
Thank you, Marc. Just a quick thank you to Marc and his team. I think as you all know, we're undergoing tremendous stress to our healthcare system. And it couldn't be possible to get the lives that we've saved in this city without the hard work of Marc and his team. coordinating care on the north side of San Antonio, and the team throughout Methodist Healthcare. I thank you for your service and your time to this city and to this community. We look forward to getting past this, but thank you for that wonderful introduction. And with that, I'm going to start my talk. Today, we're going to talk a little bit about the opioid epidemic. My goal is to help you understand a little bit about how we got here. My goal is also to help you understand why we might be thinking about this not quite in the right way, and how we can reframe the conversation about the opioid epidemic for the long haul. So, you know, I always think it's nice to start with defining a problem. And so I always start with this conversation about a patient. He's a 29-year-old male who presented to the emergency room, jumped down onto an 8-inch nail, which is about 15 centimeters. And, you know, the doctors tried to get this nail out, but it caused too much pain. And they had to give a bunch of medications known as fentanyl and midazolam. The nail was noted to enter just in front of the steel toe cap. And so the concern was that this nail had gone through some important structures, and we needed to get this shoe off in order to evaluate the patient appropriately. After giving significant medications and removing the shoe, it was discovered that the nail actually miraculously penetrated between the toes. Now, this patient exhibited extreme pain and required significant amounts of medications, but actually nothing ever penetrated the patient themselves. So that brings us to this concept of how does pain exactly work? And a good friend of mine, Dr. Ring, who's a surgeon and thinker in this field, he's an orthopedic surgeon up at Dell in Austin. He was looking at this and had some people visiting from the Netherlands, and they were looking at why do you guys give so many medications to these patients after surgery when they were visiting him and rounding with him? And so they agreed to go their separate ways. And the doctors in the Netherlands, they said, you know, let's maybe have some people who get our treatments and some people in America who get their treatments, and let's see how they do. What was very interesting is that the patients were just as, if not more, satisfied taking just regular Tylenol over the counter, which is the standard of care in the Netherlands, as they were taking opioids in the United States. In fact, more people were certainly taking opioids in the United States than they were taking them in the Netherlands. And despite this, again, the pain control was the same or better in the Netherlands, and the satisfaction with the pain relief was the same or better. And so we start to think that perhaps some component of pain goes beyond just the actual thing that caused the pain itself. In other words, how can we have these two different situations? We've got two soccer players, they hit each other, they fall on the ground, they writhe around for a while, and they don't even get up, and the referee has to come over and check on them. And then we have the person on the right, he plays hockey, breaks his nose, bleeding everywhere, and he's going to go and score the next goal, and he's not even going to think about it. How is it possible that these two people who barely hit each other can't play anymore, and the guy who broke his nose can play? And so we come to this concept that pain is very interesting and unique. There's a pain generator, in this case, the hit to the head, that was the truth for all of these people. And there are some biological factors that we won't go through today that impacted how that pain was responded to. And then there's non-biological factors. What was the situation? Were you upset that you just missed a goal, or let a patient or let somebody run by you and score a goal behind you? Are you having some financial issues? Are there other things going on in your life? And when we run a pain generator through all those factors, we end up with a pain response that varies dramatically. That's why I might stub my toe and say I have a 10 out of 10 pain, and Mark might stub his toe and say he only has a 1 out of 10 pain. Clearly, we both stubbed our toes, but clearly we both had different responses. That led to this very controversial statement written by a neuroscientist in San Diego, where he said, you know what? Pain is actually an opinion. In other words, if I had a TV up right now and it was showing all the major news networks and we were talking about the coronavirus, some of the news networks, although the input is the same, the number of people who've been infected, the number of people who've died, how many vaccines have been distributed, some of them might paint a very rosy picture and some might paint a very gloom picture. The reality of it is that each one, we would say, is providing an opinion. The input's the same. What they tell us is different. So in many ways, pain can be an opinion. And as you think about things, think through how pain as an opinion may impact how we do things in healthcare. So we look at a case study, and I'm a spine surgeon by training. This is what I do for most of my daily life. And I'll just tell you, this is a really big disc herniation. I actually have two patients. I don't use their real names, but we'll call them Mr. Roberts and Mrs. Smith, who had the same disc herniation, the same surgeon who operates on that. And I do the same surgery on both of those two patients. And we look at the outcomes. ODI is a functional score. The lower the score, the better the patient's doing. The higher the score, the worse the patient's doing. I think we all know about pain scores on a scale of 0 to 10. So you can see that both patients in the pre-op period start out about the same. They both have about the same function. They both have about the same pain scores. But if we follow those patients out for 2 weeks, 6 weeks, 3 months, 6 months, and finally at the end, we see two very different stories. Mr. Roberts seems to be doing great. He has minimal pain. He's doing very well functionally. Mrs. Smith, she's not doing very well functionally, and her pain is really high. So we have to ask ourselves the questions. What's the difference between these two patients? How often does that occur? Can we predict who's going to be a poor responder to these treatments? Can we intervene then and turn these poor responders into good responders? And what cost or cost savings occur when we actually intervene? I want to take you back a little bit and talk to you about opioids and teach you a little bit about where we came from. So this map here on the top left may remind many of you from the Gulf War. You see the Persian Gulf in the bottom right. You see the Euphrates River, and you think back, this was Iraq. And so our story begins back in about 4000 BC, and that's the first noted documentation of conversation of some form of opium. And they called the plant the joy plant. It was used in the Middle East for helping babies to stop crying, sometimes used, as seen in the bottom left, in some sort of religious rituals. And it was also used in surgery through opium-soaked sponges. And on the right, we see an actual opium plant, poppy seed, and they're taking the nectar out. And so that poppy seed, that opium, it creates 3 main compounds, and anything beyond that, we just basically manufacture. So we get morphine, we get codeine, and we get thebaine. And so we move on to these two scholars. The one on the left is actually pretty well known. You may not know who he is by looking at him, but that's Hippocrates. And he wrote frequently about opioids in 400 BC. In fact, he divided them into different colors because he thought the different colors and appearances made differences for the strength of them. He sometimes stated that we could use them as a narcotic or a pain medication. He sometimes said we could use it as a styptic or something that could stop bleeding. This concept that it was well used and was a good drug was actually not very well accepted. The gentleman on the right is Diagoras, and Diagoras was around at the exact same time as Hippocrates, but he actually made a statement. He said, "I think it would be better to suffer from pain than to be addicted to opium." And he felt that opium was just too dangerous and shouldn't be utilized. And so now we're seeing already as early as 400 BC, discussions within the medical literature, as we'll call it, that maybe opium isn't as good as we thought it might be. And so now we have our first discussion of opium users becoming opium addicts. If we fast forward a little bit to the early 1800s, we'd meet a gentleman by the name of Friedrich Serturner. He was a German pharmacist and chemist, and he wanted to try and isolate the various compounds. Remember, I told you there's 3 compounds. And so he said, I want to get the most potent compound. And so he found the most potent compound, and he named it after the Greek god of sleep, which those of you who studied or remember that was Morpheus. And so he actually found the drug morphine. And he was seeking to solve the problem that the poppy powder used to treat various conditions was very inconsistent in its potency, and it was inconsistent in its effects. And some people would overdose, and other people would say, man, this didn't do anything to me. So in order to test his new compound, he had a bunch of his friends take morphine, and they evaluated how did these doses affect their how they felt, how did it impact them. he developed a lifelong addiction to morphine. He actually discouraged its use, and he suffered from chronic depression and became socially withdrawn. His research was largely lost, and by 1827, a company that you may have heard of named Merck began mass producing Sarah Turner's drug, morphine. Opium addicts are now morphine addicts. By the mid-1800s, war breaks out, and the use of opium in medicine is well established. The Union Army actually used 500,000 opium pills and 2.8 million ounces of laudanum, which is a liquid form of morphine and codeine. The gentleman on the left is Charles Romilly Alder-Wright. He's a British chemist, and he began chemically modifying morphine in 1874. He said, listen, this morphine thing, we thought if we got to the strongest compound, we'd be okay. People wouldn't become addicted. Clearly, that's not the case. These guys coming back from the war in the United States, they're addicted. People here in England are addicted. We need to do something different. So he started boiling acids with morphine, and he created a new compound called diacetylmorphine. He fed it to his dog. His dog became violently ill and became hyperactive. Other tests he did showed it caused anxiety and sleepiness and vomiting shortly after administration. And he said, you know, I think we need to move on from this. The gentleman on the right, Heinrich Dresser, was a German chemist who actually identifies and finds and rediscovers the same compound, diacetylmorphine. He works for this young German company by the name of A.G. Bayer, which we all know today as being one of the largest producers of medications. He discovered that the new compound, this diacetylmorphine, entered the brain 5 times more readily than morphine. And given that it required reduced amounts of drugs for dosing, he said, hey, listen, this is going to work better than other drugs. It's not going to be addictive. He tested on a handful of patients, said, hey, they did really great. None of them got addicted. And he named that drug for its heroic properties. Morphine addicts became heroin addicts. You could buy heroin in your local drugstore in the 1900s and 1910s. And if we fast forward to around 1967, we have this wonderful nurse on the left, Cicely Saunders. She was working in England and created a movement that we still use today and very much support, which is the hospice movement. And she said, you know, people should stop living their days in pain. They should be provided with pain medications to whatever level is necessary to keep them comfortable. And I don't care if it's heroin or morphine, they deserve to get it. And in 1984, legislation in this country termed the Compassionate Pain Relief Act was passed, permitting the use of narcotics, including heroin, for the terminally ill patients. Her viewpoint is still largely endorsed by physicians around the world today. The gentleman on the right, in 1985, 1 year after the Compassionate Pain Relief Act was passed, in 1985, he began lobbying, this should go well beyond hospice patients, that pain relief should not be relegated only to the terminally ill. And he said, you know what, doctors, you guys in the United States, you have this thing called opiophobia. You're afraid of opioid medications. And largely as a result of his outspokenness on the issue, pain was created as a 5th vital sign. In a frequently cited 1986 paper, based on just 38 patients, Dr. Portnoy and Dr. Foley concluded that opioid maintenance therapy is a safe and more humane alternative to the options of surgery or no treatment in those patients with intractable non-cancer pain and no history of drug abuse. The American Pain Society introduces the 5th vital sign. The Federation of State Medical Boards begins releasing policies saying doctors will not be prosecuted even if they prescribe large amounts of medications as long as it was in the course of regular medical treatment. The Joint Commission, which accredits every one of our hospitals, began creating standards that stress patients' rights to assessments and treatment for pain, emphasizing that pain should be assessed in every patient. They published a guide that was sponsored by this company called Purdue Pharmaceutical. And they stated some clinicians have inaccurate and exaggerated concerns about addiction, tolerance, and risk of death. This attitude prevails despite the fact that there is no evidence that addiction is a significant issue when persons are given opioids for pain control. Policies were drawn up then with the help of several people with links to opioid manufacturers, including David Haddix, who was a senior Purdue pharmaceutical manufacturer and executive then and up until recently. The Federation received nearly $2 million from opioid makers. Meet Arthur Sackler. His name may be familiar to many of you now. The American history books will now point to him and his family as the author of one of the worst epidemics in American history, the opioid addiction. Dr. Sackler and his brothers were all physicians. They bought into an advertising firm named Williams, Douglas, and McAdams of New York, where they lived. They discovered multiple ways to use Valium and marketed it as such, making it the first drug to ever eclipse $100 million in sales. They were key to the marketing of multiple other medications and they even sit in the Hall of Fame for medical marketing. Their contributions shaped everything we know in pharmaceutical sales today, from utilizing dinners to gifts to influencing physicians to utilizing medical journals and direct-to-consumer advertisements. None of these occurred prior to the Sackler family utilizing them to a great degree. They purchased a small company called Purdue Frederick and Company in the 1950s, utilizing their advertising and knowledge in psychiatry to create the most lethal ad campaign the world knows. Heroin addicts became opiate addicts. If you look at how much money was spent, absolute dollars, on opioid analgesics in the first 6 years, if you look on the bottom left, it tells you the year that those drugs were introduced. So the clear one is MS-Contin. That's a long-acting narcotic morphine. Very similar to the other drugs, OxyContin and Duragesic on this. If you look, very little money was spent on OxyContin from 1984 to 1989 marketing this. From 1991 to 1996, before pain became a fifth vital sign, Duragesic had very little marketing. In 1996, OxyContin comes out. They more than double the amount of advertising for OxyContin than had ever been spent on a narcotic in history. And they get to nearly $30 million in promotional spending by year 6. And if you ask myself and other doctors who either treat patients in pain or who prescribe pain medications, is there really any difference between these various pain medications, oxycodone, hydrocodone, in how they help pain? Granted, there are differences in potencies. Is there any difference between the drugs? The answer is no. Oxycodone had been around for a long time. In fact, we've got data dating back to 1980. And you see from 1980 to 1996, remember, pain is a fifth vital sign. Advertising and marketing, OxyContin hits the market all in 1996. You see a massive extrapolation in the amount of oxycodone used, even though there's really no evidence to suggest that oxycodone is any better than any other drug on the market. If you look at patients who are prescribed opioids, the risk of continuing opioid use spikes somewhere around the 5-day mark. So this graph looks at the number of days of the initial opioid prescription. And most people, at least early on in the opioid writing career, wrote for 30 days of medication. And if you look at that 30-day mark, 20% of patients will still be on opioids at 3 years if they're given a 30-day prescription. And nearly 35% to 40% will still be on opioids at 1 year if you prescribe a 30-day prescription of opioids only on that first prescription. Now we've created rules and regulations that say you cannot prescribe more than, depending on the state, 5 to 10 days worth of medications. And the reason why is because they're trying to stop this curve. They're trying to prevent people from becoming long-term opioid users. And we know that if you look at the amount of narcotics that are taken, that dramatically increases the risk of people dying. And so I'll tell you that in the left column, that's 1 to 2 hydrocodone 10s per day. The second column, that's 2 to 4 hydrocodone tablets per day. The third column, that's 5 to 9 hydrocodone tablets a day. And the right column is 10 or more hydrocodone tablets a day. You can see that if we set the baseline as people who take less than 2 hydrocodone tablets a day as kind of the baseline, you get a 45% increased risk of death when you jump from 1 tablet to 2 tablets. When you jump from 2 tablets to 5 or more tablets, you have a 273% increased risk of dying compared to someone who takes no narcotics or 1 narcotic a day. That number extrapolates up to 787% if they're taking over 10 hydrocodone per day. And now that led to the point where Americans are more likely to die of an opioid overdose than they are to die on the road. Americans now have a 1 in 96 chance of dying from an opioid overdose versus the probability of dying in a motor vehicle crash of 1 in 103. And there were enough overdose deaths to fill the average NFL stadium in 2017. And you know, we thought we were doing something right. In 2018, we began celebrating. It was actually in 2019 when we got the 2018 data and we said, hey, we finally bent the curve. We finally flattened it. From 2017 to 2018, nationally in the United States, we had the first drop in decades. But that didn't last. In 2019, we broke the record of 2017 in drug overdose deaths. And then the coronavirus epidemic happened. And monthly overdoses grew dramatically during the pandemic. And for every 10 suspected overdoses reported to the federal government in May 2019, there were 14 overdoses reported in May of 2020. And if you look, as the pandemic kept going from January to February to March to April to May, the percentage increase year over year continues to extrapolate. We don't have our 2020 data yet, but we know that the numbers are overwhelmingly higher than they were in the record year in 2019. Now, we were talking about the number of people who die, and this is where we're going to make the turn. I want you to think a little bit about this. It is incredibly horrible that 130 people die every day from opioid overdose. That's more than 400,000 deaths since 2000. And a friend of mine who's on tonight sent me a note that said, more people have died of the opioid overdose epidemic than died in all of World War II. And that is a horrible thing. But what's even worse is that we have even more people living here today among us dealing with opioid issues. Because for every one person who dies, there are 10 people who are admitted for abuse. There are 32 emergency room visits for misuse or abuse. For every one person who dies, there's 130 people who abuse opioids or are addicted. And for every one person who dies, there are 825 non-medical users. When we look at the National Institutes of Drug Abuse information, roughly 21 to 29% of patients prescribed opioids for chronic pain misuse their medications. And 80% of people who ultimately use heroin, so the people who end up in the pool that typically dies, first misused prescription opioids. If we're going to get to the solution, we've got to get back to the root. And if you look at some data that recently came out for past year prescription pain reliever among patients by selected pain reliever subtype, it's very interesting. The left part is the total population. The right part is the users, okay? And look at what we see. The people who misuse the medications, two of the three most commonly misused drugs are buprenorphine and methadone. If you look at what we're trying to do as a country to try and solve this problem, we're pushing Suboxone or buprenorphine and methadone, and yet those are two of the most highly abused drugs in the United States. And if you look at this graph and you look at the percentage of people with heroin use, only 340,000 people who misused opioids only misused heroin. That only represents 3.4% of the opioid misusers. That means that we have another 96.6% of opioid misusers who are misusing pain medications, some of which are also misusing heroin and will ultimately flip over into the small 3% of opioid misusers. We've got to focus our attention on the opioid misusers. Despite the fact that we're writing tremendously increased numbers of medications for patients over the last 30 years, When we ask patients whether or not their pain is being relieved and whether or not they're in pain, what we see from 1998, just after pain is the fifth vital sign is introduced, to 2010, according to the Health and Retirement Study, we see that the percentage of people saying they're in no pain continues to reduce over time. And the percentage of people who are saying that they are in mild, moderate, or severe pain is increasing. And remember, layering over the number of medications we're writing over the top of this graph, we see a dramatic increase in the number of pain medications that are being prescribed. And yet we still see these increasing numbers of people on pain medications. So if we have more people taking pain medications and they're taking it in order to relieve pain, and we're thinking that pain relief is the offsetting to the risk that we're taking for the patients having a complication, ultimately becoming a misuser and potentially someone who dies, then theoretically we should be helping their pain. If the pain isn't getting any better, now we really need to look at how does this impact the cost of healthcare? So for all of you who are healthcare administration on the audience and healthcare in the audience, I think you'll appreciate some of these next few slides. If you look at a study recently published by the Journal of Bone and Joint Surgeons, and we looked at patients who utilized opioids before surgery. Might have been 1 tablet a day, might have been 10 tablets a day. But if we looked at people who took opioids for at least 6 weeks before their surgery, and we followed them out after the surgery, the risk of a readmission went up 13% in total knee replacements and 46% in total hip replacements. If we looked at revision rates at 1 year and 3 year, and these things should last a lifetime, if not 20, 30 years, the revision rates, the increased risk of a revision was 61% higher and 120% higher in total hips. That carried out to 3 years to about the same numbers for both total knees and total hips. If you look at spine surgery on patients who take opioids before surgery, they're 19% more likely to have 90-day wound complications, 10% more likely to have a new pain diagnosis, 31% more likely to use the emergency room postoperatively, 80% more likely to get readmitted to the hospital, 708% more likely to continue using opioids after surgery, and 124% more likely to utilize injections after surgery. And finally, they're 33% more likely to have a revision surgery because of their preoperative opioid use. If you look at cervical spine cases, patients who were on opioids before surgery of their neck were 5 times more likely to be on narcotics postoperatively. Only 51% of the patients on opioids before surgery had a good or excellent result compared to 86% in the non-using group. And of all the patients who had poor results, all of them came out of the group who was using opioids. And if you look at the total number of surgeries that are performed in hospitals like Methodist or Baptist here in San Antonio or anywhere in the country, total knees, total hips, and spine surgeries are the numbers 1, 3, 4, and 5 procedures performed in hospitals. So now we know that these patients are high risk and they're the most commonly performed procedures. But what if we look at the next 10 surgeries? What do we see? Abdominal surgery, abdominal surgery, abdominal surgery, abdominal surgery. So what about patients who are getting ready to have abdominal surgery? What do we know about this group that rounds out the top 10 of procedures performed? Well, somebody looked at this and they looked at preoperative opioid use and its effects on outcomes. And what we saw in abdominal surgery is that patients who were on opioids before surgery had an increased 90-day hospital costs of $2,341 higher, more likely to have surgical site infections, more likely to experience infections in their bloodstreams, more likely to have an unplanned re-intubation where we put the breathing tube back in, more likely to have a heart attack after surgery, more likely to require a blood transfusion. They stayed in the hospital for a longer period of time, and they were more likely to get readmitted to the hospital. The authors of this study had something very profound to say they said, our findings suggest that opioid use is common. It was over 20% of patients were on opioids before surgery, before major abdominal pelvic surgery, and represents a novel target for surgical quality improvement. This study was done at the University of Michigan for people inside the state of Michigan, and they said the financial impact of preoperative opioid use in this population, that population is elective abdominal surgery, is $184 million annually in Michigan alone, even after adjusting for other drivers of increased cost, even after looking at whether they were diabetic or whether they had hypertension or heart disease or other things that we know increase the cost of care. Another $184 million was spent annually just on patients who are on opioids before surgery. So if we say it's 20%, if we look at surgical studies, 20% of patients have suboptimal outcomes, 20% of patients are on chronic opioids and they have significantly worse outcomes. We know that there's about 10 million inpatient procedures and another 10 million outpatient procedures. And that's another 4.5 million people every year who are on chronic opioids before surgery. If we extrapolate that down to San Antonio, it's about 120,000 people in San Antonio that get surgery every year between inpatient and outpatient surgeries. And that equates to about 25,000 patients who ultimately are on chronic opioids and have suboptimal outcomes every year in the city of San Antonio. So if we extrapolate this out to Texas, they said it cost $184 million for elective abdominal procedures in Michigan. Well, Texas population is about 2.7 times bigger than the state of Michigan. And that means that for elective abdominal procedures in Texas, we spend about $500 million extra on patients who are on opioids going into surgery. And if you look at the numbers that we showed about how many procedures are done every year, elective abdominal procedures only account for about 20% of all procedures performed. And so if we multiply by 5, that means that we're at nearly $2.5 billion in excessive spending in Texas annually, including all procedures related to patients on opioids preoperatively. And that's just the cost of care in the first several months and doesn't include the additional cost of patients on long-term opioids. But there's more. Opioids are only part of the problem. We found that patients with underlying depression or anxiety also have worsening outcomes. They have significantly worse satisfaction. They're more expensive to care for in the first year, and they're more likely to take opioids after surgery. And we know that patients on long-term opioids are expensive. If you look at the Milliman study, and Milliman is one of our groups, it's an independent group that looks at many different things that impact healthcare. When they looked at it, they looked at patients who are they called as super users. These are patients on chronic opioids at least 2/3 of the year. Didn't matter the dose, they just took at least 2/3 of the year they took an opioid. Then they looked at patients who were diagnosed as addicted to opioids, and they looked at everybody else. They found that chronic medical conditions in the chronic users, the people who we called super users, was 85% versus only 60% in the opioid use disorder and only 30% in the non-users. And if you look at the total cost of care, it's no surprise that patients on chronic opioids cost about the same as those that we make the formal diagnosis of addiction to. In fact, patients on chronic opioids cost somewhere between $16,000 and $20,000 more per year to take care of. So we've got the $2.5 billion in excessive costs on the patients we do surgery on, and every one of those who end up on long-term opioids, for which they're about 500 to 700% more likely to do if they go into surgery on opioids, are going to cost us every year for the rest of their life approximately $16,000 to $20,000 more per year. So what are our challenges at this point? Well, one of the problems for treating patients is that, a lot of patients who ultimately get treatment have to go long distances to get their treatment. It's not typically local. It's not in their neighborhood. It's not close by. It's maybe not even in their city. They may have to travel outside their city or outside their state to get the care. The care that's provided is typically in increments, 30 days or 60 days or 90 days. We don't provide these patients with long-term access. And our treatment options are typically very segmental. You go to one doctor for one thing, one doctor for another thing, one doctor for another thing. The surgeon's seeing you for your surgical problem, the primary care doctor seeing you for your medical problems, the pain management doctor seeing you for your pain problems, and having to coordinate all of this care is extremely difficult. And it's usually not coordinated from one group to the next. Usually the surgeon doesn't necessarily know what the other doctors are doing. Many of the costs are billed that require a higher out-of-pocket cost for patients when we try and bring things under one roof. And so the solution is to bring things together in an easy manner at a lower cost to both the patient and to the healthcare system. So where do we go from here? I don't know that I have all the answers. Here in San Antonio, we started a program we call the pre-op assessment. It's run by our company here at New Hope in San Antonio. And what we're doing is we're getting ahead of this. We're evaluating patients for the problems we know are going to cause issues long-term. We're working to get in front of the problem before the patients become long-term opioid users, or taking long-term opioid users and working them off their medications. We have about a 70% success rate of working all the patients off opioids, and we have a 100% success rate at eliminating drugs that they shouldn't be taking together. I'm not saying we know what to do or how to do it every time, but I will tell you that we've got to get our hands on the costs of care of opioids much beyond the people who are dying. The people who are dying is an incredible tragedy, but the cost of the people who are still alive to our healthcare system is an even bigger tragedy. And if we don't get in front of it, the people who are taking chronic opioids, unfortunately, some percentage of those will become those who die. We can save our healthcare system a tremendous amount of money up front by working with these patients, ensuring that they are optimized prior to surgical treatments and ensuring that they're optimized after surgical treatments. By doing this, we save the healthcare system money, we save the patients money, we improve outcomes, and ultimately we end up with a better solution. So I'll end with the same question I started with, and hopefully I've helped you understand a little bit more about why the opioid epidemic matters. I think I've hit right at about 45 minutes, so we're happy to take some questions and create some dialogue around this different thinking about what's going on with opioids.
Dr. Bruggeman, thank you very much for your insight on the topic. It was a very enjoyable presentation to listen and learn from. And I want to thank everybody that has logged on with us this evening for taking part in tonight's lecture. It's now time for the Q&A session. And if you haven't done so already, and I do see some questions coming in, please submit your question using the Q&A tab. I'll read out the questions so that Dr. Bruggeman can answer them accordingly. And Adam, I'm going to throw one out there just from a hospital administrator's perspective and get us started here. When I think about our clinical agenda and our clinical scorecard, particularly as it relates in the realm of surgical services, there is more focus now than there's ever been on ERAS, advanced recovery after surgery. And not a new topic. I think it's been around longer than you and I have been in the field, but it's getting more attention now. And I'm just curious from your standpoint, we track it. Obviously, we're trying to get more surgeons to adopt a multidisciplinary approach. But beyond just implementing the protocol, what else could hospitals and a hospital administrator like myself be doing, maybe throughout the process or on the back end, to make sure that it's actually working?
Yeah, so I think ERAS is great, except it typically ends at the discharge. And so one of the things to coordinate care on the back end is either having, if the hospitals don't have the resources in their community, creating a resource that's going to continue with that patient on a long run. In other words, at up to the 90-day mark where you're typically being looked at, or 180 days, depending on which metric we're looking at, or partnering with community organizations that can carry that ERAS protocol out to ensure that what's happening in the hospital continues post-operatively. Unfortunately, a lot of times, because of the discoordination of care, another doctor gets involved, say pain management or primary care, doesn't know what we've already accomplished in the hospital, and basically kind of undoes what we did inside the hospital, and gets that patient back on maybe an unhealthy dose of medications or in a bad position.
Yeah, it is a challenge. Here's a question that comes in. Can you talk briefly about multimodal anesthesia, analgesia, and if any data has shown a minimization of post-op opioid use?
Yeah, so I think that dovetails on what Mark just talked about. So one component of ERAS, the enhanced recovery after surgery, is this preoperative dosing of things like IV Tylenol, utilizing a cocktail of medications before surgery, using a cocktail of medications in the post-op unit, having the nurses be aware of certain types of treatments they can provide. It has been shown to improve things. How much is obviously a question mark for all of us, but definitely multimodal analgesia has certainly helped perioperatively reduce post-operative pain medication use.
Okay. Here comes a question, I think specific to how you practice, Adam. In your typical spine surgeries, what are your usual pre-op and post-op orders regarding pain? And do you find that differs much from your peers?
Yeah, so that's one of the things we're studying, and it's very interesting is we're looking at what's going on in our community. Unfortunately, we all operate in silos, and so preoperatively, I send all my patients over to New Hope. They get into the pre-op program. They begin working off opioids if we have enough time. If they're on them before surgery, after surgery in the hospital, I don't utilize PCAs anymore. I think those were very commonly used. We stopped using them in my practice. Haven't found any concerns about it. It significantly reduces the IV narcotic use. When we look at the community of doctors, though, and the same doctor, different doctors do the same surgery, what we find is that people provide drastically different types of medications, drastically different strengths of medications, and drastically different amounts of medications. One surgeon for a total knee might prescribe 90 or 120 tablets, and another surgeon might only prescribe 30 tablets. And we're trying to get our head around that. We're actually using data and information to try and identify if a patient comes in with these risk factors, they're on average going to take this many medications based on our data that we're obtaining internally. And so preoperatively, we're not giving them more medications than they actually need.
Here's one, and I can relate to this, because as we look to create a great experience for our patients, one of those questions that we ask is, how are we managing your pain? And this question or comment comes in and says, unfortunately, most hospitals pre and post-op nurses ask questions that reinforce the need for medication. In this person's response, they themselves had back surgery. They kept getting asked every couple of hours and trying to sleep for the first time. Comment is we need to set expectations in the office and the pre-op, post-op settings and with all treatment providers. Do you agree with that?
Yeah, exactly. That's one of the things we work on all the time. We talk to our patients about expectations before surgery, after surgery, during surgery. And I think the nursing staffs can work on their component of it too. We still ask the question, but there's ways we can ask questions that encourage certain types of answers. And so if we ask the question incorrectly, we're going to get, yes, I'm in a lot of pain. And so obviously we've got some issues at a federal level that we're being graded on these things. And if you're being graded on it, unfortunately, that's ultimately going to lead to behaviors that may not be in the best interest long-term for the opioids.
Next question. Do you think there is a genetic predisposition to opioid addiction?
To be determined. There's a lot of genetic studies that have been done. There are some genetic markers we have tied to other addictions. We don't have any data yet on opioids. It's certainly an area that we are working to potentially partner with a variety of organizations to study and look at patient populations and see if certain markers are more likely in not only in maybe patients who are addicted, but maybe even patients who end up on chronic long-term opioids. Are there certain genetic factors that make that patient more likely? And if that's the case, could we draw those markers prior to surgery and use that as part of our risk scoring to understand this patient better and better manage their pain perioperatively to ensure they don't end up on long-term narcotics.
Here's a question from one of the HCAD students from yours and my alma mater in the program there at Trinity, asking, in general, what should be the primary roles of healthcare providers in curtailing this epidemic? And he specifically calls me out and says, what are the hospitals doing around this? Like I mentioned, much greater focus than when I started my career around efforts like ERAS, but probably still not doing as much as we could. You have any comment on that, Adam?
Yeah, I think the problem is that so on the hospital administration side, obviously you can't practice medicine, and so as administrators, we can encourage, we can show data, we can ask for help, but ultimately, the ultimate decision is made by the doctor. And so there's only so much we can do as administrators, but you got to create an environment that, I will give Marc some kudos. I mean, he creates an environment where surgeons are comfortable talking to him, comfortable with suggestions from him and his team. And so I think you create a similar environment to what he's created, and you'll have much more success. As far as on the provider side, obviously, we've got to get our handle around what's the right pain medication to give at the right time for the right person. And I think that most private practicing doctors don't have that. And that's why we're trying to research that, study that at our company, and get a better understanding of that so we can get better information to surgeons to provide better care.
One more here. The question comes in, what symptoms can I look for to tell if a loved one is overdosing?
So most opioid overdoses, the actual overdose itself is due to the breathing that stops. So, blue around the lips, they begin shallower breathing, and then obviously stop breathing. Unfortunately, there's not a lot before that happens to know that an overdose is occurring. As far as behaviors that are concerning for people, there's a whole laundry list of things that we ask our patients about opioids. There are some shorter questionnaires that can be utilized, but really, is it affecting or impacting their daily activities? Are they worried about where their next medication is going to come from? Have they missed work or missed important activities because of their medications? Are they not able to do certain things at work because of their medications? Are they, hopefully not, but are they participating in any illegal activities in order to get these medications? Are they lying to family, friends, or physicians about their medication use? All those things would be concerning signs and symptoms. And typically mood changes do occur as well. People become more difficult to be around, their moods swing more heavily. Those can be some signs and symptoms that things are on the wrong direction.
Okay, here, and we've got time for a couple more here. Do you think that there is an opportunity, for the different boards, meaning, like the medical society and the pharmacy boards, to collaborate greater than, currently are?
Yeah, I think it's hard because doctors have now kind of retreated to their specialties. So, orthopedic surgeons listen to the Texas Orthopedic Association here, or the American Academy of Orthopedic Surgeons. And so we've siloed within our specialties, and we really do need more interspecialty communication and agreement. The American Medical Association, if you go on their website, has put out a tremendous amount of information. I would say that our anesthesia colleagues have probably done the best of all of the specialty societies at working this. And I think we're all looking to create what we call pain toolkits, which we're collaborating on as various specialties to teach our physicians in our various specialties, what's best practice? How do we do this? And just recently I had to record a 2-hour CME that's required for every single Texas doctor to use, not necessarily mine, but a similar one, in order to renew their license within the next 2 years.
And our last question is, what are the differences between opioids and heroin, if there are any?
It's a matter of potency. Heroin is an opioid, so it's a subclass of opioids. And so one of the, there's a book out there, in fact, that's called Drug Dealer MD. essentially stating that as physicians, there are medications that we prescribe that are illegal if taken outside the prescription of a physician. And so oxycodone, hydrocodone, Percocet, Tylenol 3, tramadol, those are all drugs that are to some degree are the same as fentanyl and the same as heroin. And so actually fentanyl is far stronger than heroin if we were to categorize them as far as their strength and ability to potentially kill people. And so I think they're all on a spectrum. We do have very dangerous tools at our disposal. I do want to say, in case the message doesn't come off right, there is a time and a place for opioids. Any of you who are on here who've had surgery and had a major problem will say that, you know, for a period of time, it's not inappropriate for these types of medications. If you break a bone, it's not inappropriate to give those medications, but there has to be some definitive end to that. And if we don't get our hands around it, we'll be in trouble.
Thank you again. Wonderful presentation. I hope everybody has enjoyed this evening's event. For more information on future webinars and podcasts, please visit trinity.edu/alumni. As I mentioned at the beginning of the presentation, this evening's lecture is approved for CME credits. You should have received a reminder email for this lecture that also includes steps on how to claim your CME credit through the Texas Orthopedic Association link provided. Our next food for thought lecture is scheduled for February 3rd at 5:30 p.m. Central. Trinity University professor Thomas Jenkins will explore Iliad from stage to page, and Anthony Tresca, class of 21, will moderate the discussion. If you would like to sign up for the upcoming lecture, see the registration link in the chat box. Thank you so much for joining us. On behalf of all Trinity Tigers, have a great night.